with a little bit of conversation amongst us. I'll give you a little bit of my background just to set the stage a little bit, and then introduce Jennifer for us. So, for those of you who don't know me, I'm the chair of the Division of Epidemiology at OSU. I've been here for a little bit over just about 2 years, not quite 2 years yet. And I'm also trained as an infectious diseases physician. I don't practice medicine anymore, but I did up until a couple of years ago. And my entree into the world of substance use really began when I was a resident. I did my training in Baltimore in the late 80s, early 90s. And parts of Baltimore are a pretty rough place, as you might imagine. And it was really as HIV was just taking off. And at that point in time, we didn't have treatment, really. We had just the beginnings of AZT at that point in time. And on our service, we would routinely have about half of our list of 30 patients that the group of 4 of us would be taking care of were injection drug users. Why? Well, because they also had HIV. And they would be there for some HIV-related complication, or they would be there for some complication of their substance use, like having an infection on their heart valve, and it takes basically 4 weeks to treat that. And at that point in time, we didn't send those folks home. They sat waiting to be cured. And I spent a lot of time talking to these folks. There was a lot of stigma then, still a lot of stigma now. Generally speaking, people didn't really want to deal with them. So I just found myself sitting in the room when I was on call, talking to people about their lives and how they got to where they're at. And every one of them had a story, often really tragic stories. And I took care of a woman who was 73 years old and had been snorting heroin for something like 50 years. She was doing okay. She managed it. I wasn't going to convert her at that point. I just wanted to listen to what she had to say. And I think in this current situation, it's changed some, but a lot of things are still the same. Certainly in our cities, things are not that much different. But now we have some problems in the rural areas. And I would just say, related to the rural areas, that addiction is not a new thing. Alcohol goes back to our colonial period, heavy alcohol use in rural areas, and people adapt to the current situation, whether it be alcohol, methamphetamine, or now heroin. They cause different problems, and so our response to them has to be different, but fundamentally addiction is addiction, and dealing with that is one of the things that we have to do. So just a couple of points, and then I'll introduce Jennifer to bring home the message. For heroin and opiates, we've had a 398% increase in unintentional drug overdoses in Franklin County from 2003 to 2016. And heroin gone from 175 to 1,400 in 2015, and it's higher than that in 2016. I just don't have the number for that. And fentanyl went from 0 in 2011 to 1,100 in 2015 as overdoses. We lead the country in fentanyl overdoses, carfentanil overdoses, and heroin overdoses. But we'll also hear some hopeful stories of how we lead the country in recovery as well. And of course, we have challenges with what, in addition to what the addiction creates, we have challenges in the consequences. So hepatitis C, we have a huge increase in the number of hepatitis C. It's increased by 1,000 times since 2011. That's pretty inconceivable almost. And one thing to remember is the consequences are preventable. If we have access to needle exchange, there's only 7 in the entire state of Ohio. That's pretty limited. We can prevent overdose with naloxone. People just have to have it and have it available. Now, when people start taking carfentanyl, naloxone is a bit of a challenge if they even survive long enough to be able to have access to it. So there are lots of challenges, and I think that we as a community don't really know how to respond. We know stigma is still a huge issue. I was speaking with a county health commissioner a few months ago, and he said he would love to offer naloxone and develop a needle exchange, but he was afraid to, because if he did, his community would cut off his funding for all the other projects that he was interested in. So it's a real challenge. So with that little bit of introduction and rambling, let me introduce.
You can keep talking, then I don't have to. So.
Let me introduce Jennifer Lloyd. So Jennifer is the director of the statewide outreach on substance use for Attorney General Mike DeWine, and her leads a team tasked with providing community outreach to address the opioid epidemic, and is a recipient of the Attorney General's Pride Award for this work. So Jennifer travels around the state talking to communities, helping them develop strategic plans, helping them figure out what they already know how to do and maybe haven't realized that they know how to do.
Often, yeah.
And then helping them figure out what they could do when they haven't figured it out quite. And she's had a variety of previous positions sort of in sales and sales management. I think that would probably come in handy in this because you have to explain things to people. And she has a master's of science in psychology, which undoubtedly contributes as well to this. So let's welcome Jennifer, and I'll pass the baton to you for now.
Okay, so I'll just sort of describe what my team does for Ohio Attorney General Mike DeWine. And although this is very hard work, we're also know that we're fortunate to be in these jobs, but it is very hard work. When I started in 2011 with the Attorney General, I believe there was about 1,900 overdose deaths. And in 16, in Ohio, we had 4,050. And I think you should think about that number for a minute, because I see faces. I wish everybody saw faces. That's a horrible number. And the expectation is that 17 will be significantly higher. So at the moment, we're probably every day losing about 15 people in Ohio. And what's kind of astonishing about that, and it goes to stigma, is that if that was something else, 15 today, 15 tomorrow, 15 the next day, in 4 days, 5 days, that's more than were killed in Las Vegas, right? In just 2 days, it's more than were killed recently at the church. And yet, there's not a massive response to it. And that's very unfortunate. So what my team does with that in mind is we try not to just listen to that, because that's very hard. But we also want to be respectful to those who are part of that number. And it's certainly not just the 4,000. This is something with tentacles. And so what we see are destroyed families, destroyed communities, children with extreme trauma that will likely get into high-risk behavior because of that trauma. And we've got another wave coming if we don't help them, help the children. So what we really do is we are very action-focused. Attorney General Mike DeWine is very clear to us that we go out and we get things done. And we had kind of this joke in my office where a friend of mine went in and said, was expecting to get all these accolades for a program she had done. And he kind of said, I don't care what you did yesterday, tell me what you're doing tomorrow. So we are a heroin unit that is very aggressive and active and passionate about the work. So we have done many conferences. We are very big believers in kind of this ideas concept where we had a conference, our first one, Ideas That Work, which all that is sharing the tremendous efforts from Ohio that are making a difference because we're isolated and people don't know. Even in the same counties, sometimes they don't know what services are available. And Ideas in Motion, which was kind of now you have all these ideas, how are they working? And we just recently had an Ideas in Practice, which was for medical profession. And I will tell you that when I started in 2011, nobody would have said this is a medical issue. In 2011, this was a moral failing, right? We've come a very long way that we could hold a medical conference and have 700 people attend from around the state who see this as a medical issue and want to help in this realm. That's a big change. So we go out, the main thing is to go out in communities and help them. And I will give you a recent example because it's very hard to describe what we mean when we say we help create action. So I think everybody is familiar with Scioto County. It was kind of the hub of a lot of this. And certainly if anybody hasn't read Dreamland by Sam Quinones, that's a good book to read to learn more about it. He spent a lot of time in Ohio, a lot of time in Scioto County. And they've been dealing with this for about 20 years. So imagine what that's done to a community that's been doing this for 20 years. Imagine what that might do to children when this is all they've ever known. I mean, that's pretty significant. And imagine what it does to a community when part of that is loss of jobs and disease and death and trauma. And so a lot of what we have to do is get people to move forward and have hope again. Because if you don't have hope, it's very hard to move forward. So we did what we call an action meeting in Scioto County, where we work with them and say, bring the people to the room who are the difference makers here. Because I don't know necessarily who that person is. And we need a wide group to come to the room. And they come and we say, what needs fixed here? It's not that hard. It's about listening, not just talking. And they write down what else is needed. And as they talk, themes come out. And in that county, there's a pretty strong theme of trauma of children, the overrun foster care system, and how do we help these kids? These kids who, at one school, 90% below the poverty level, who have maybe one outfit to wear to school, who are not brushing their teeth because they don't have toothpaste or a toothbrush and aren't cleaning. And oftentimes are the ones staying up all night while their parents detox. And then they're late for school and tired. And then the other thing that came out was about 8 pastors or faith leaders were there who said, we want to help, but we are not sure what to do. And we hear that a lot too. More and more, thank goodness, we hear people say, I want to help. What can I do? Didn't used to hear that either. It was like, that's not me. That's not my family. That's not my kid. Yes, it is. And easily mine. And the other theme that came out was that they needed help because if a child's going to school with extreme trauma and helplessness, the kind of curriculum that you need to teach them about drug issues is very different than it might be in a different school. So they need help with bringing that curriculum, the right curriculum, to their children. So since that meeting, and we'll do more, we had the educators come to Columbus, started sharing some programming with them, and connected them with organizations like Big Brothers Big Sisters, who weren't there in Scioto County and are needed there in Scioto County. We let them know about there's OMAS, Ohio Mental Health and Addiction Services, has a grant where you can sign up for free for PACS behavioral good behavior games for your teachers. That's very different. It's much more about social and emotional learning. And you have to start early in kindergarten. The Attorney General has been very clear about that we need curriculum K through 12 in the schools. For the faith leaders, we had a good meeting with them to plan a conference. And when we do conferences anymore, they're not just a whole bunch of people talking and everybody leaving. You're going to learn what to do while you're here. And you're going to learn what resources are here. And you're going to walk out of here with a plan so you can. And what we'll do in Scioto County, because they said, we don't know what to do. Again, we don't know what to do. And often with faith, and we've had tremendous help from the faith community in Ohio, is we say, it's simple. Stay in your lane. Just stay in your lane, but just do it with this group. Someone in my office today was working on, we got a call about a woman who couldn't afford to bury her child. So that's a pretty good lane for a faith community, wouldn't you think? Helping this family bury their child, right? So that meeting will be set up to teach them about resources, to show what the gaps are that the church can fill. And I will tell you, we break it down to small things so that if you make something too big, like we need a treatment center, it's very hard for people to do that. But if you give them small things that they can do and get engaged and feel proud of the work they're doing, you can move mountains. So that's really what we do. And every community is very different. So our approach to them has to be very different. In Pickaway County, where we did a lot of work in a time when our death rate's soaring, and they do a lot of work, we helped. Their death rate between 2009 and 2016 is down 150%. So we know that it can change. And that's what drives us forward, because it would be very hard to do this work, and all I paid attention to was 4,050 people dying in Ohio.
That's great. So we can open it up for questions from the group, from questions from our YouTube watchers. This is intended to be more interactive than just the two of us. So I'd like to start with something from y'all.
I've been jotting a bunch of questions down, so stop me if I get just.
As long as they're not personal, we're pretty good.
Is there a protocol or a desired way of handling a citizen in the community who is a heroin or an opioid user, and we know that person wants to quit? And let me just hit my next two. The second version is same kind of situation. They sometimes want to quit. The third version is as long as they can get their heroin, they don't want to quit.
Right. So number one, I wouldn't say there's a protocol. I will tell you, every single situation is very different. And the motivation for wanting to stop using is very different. They're very afraid of detoxing. It's a life they've gotten used to. They feel that, in many cases, not all, but in general, they have lost their family, their friends, their money. And it's a little terrifying to even think about changing their life, as interesting as that may sound. And every community is a little bit different. You know, you have communities that have a lot of great things in place, and there's a lot of resources, and there's a lot of treatment, and then other communities where there's very little of it. And I think part of the problem we see is you have, that's again this isolation issue where I could be in Marietta and there's not much treatment, and I am not aware that two counties over there is, and so I can't divulge much about something, but we need to do a better job of letting people know easily where there's an open bed. And we're getting closer and closer to that I can't talk about. But, and then, you know, a person who doesn't want to, I don't think anybody wants to be in that situation. I've known a lot of people who say, I don't want to. And when you really get to know them, yes, they do. They just don't know what to do. And they're hopeless. So there's more about that. If you start giving them hope and letting them believe their life can be different, I think that they can believe that and move towards it. But if they just think, why live, which is, every time you stick a needle in your arm, particularly right now with fentanyl and carfentanil, you have a chance to die, right? So many people don't see a path out. So why try, right? So we do better with getting them on a path, better job training. And these are all things we work on, and the community works on. And honestly, what we see a lot of within the faith community is, and I'll give a very specific example, out of Pickaway County, we're in the jail, which is kind of our largest detox at the moment. The jail, while inmates are there, they get them assessed. They, if they choose, can write up a surveys type of thing that they write out how they're going to live better upon release, how they're going to remain clean and sober, and an officer, the Job and Family Services, the jail administrator in the jail, and if they're seem motivated upon release, they get signed up for Medicaid, which covers much of this medication-assisted treatment. The judge to the treatment center. Sheriff's deputy drives them to the treatment center, and they start on trial, right? Opiate blocker. But what I saw as the big change there, aside from all that, because that's not enough, a lot of life building to do. Because, you know, if you use Vivitrol, you can still use cocaine, right? It's an opiate blocker. But what they did while this was happening is the jail administrator called a church, and they assigned a church family to walk alongside him upon his release. And when told that, I mean, he broke down and cried. He never had anybody help him in his life. 19 years old, and he's doing really good. So it's interesting how all of those services existed. Didn't cost any more money. It was just the community deciding that he's worth it when he didn't think so. I hope that answers it.
I just have one little thing to add that sort of reinforces that point nicely. And this is, so one of the things I didn't mention is I got into the world of substance use internationally, not domestically. I worked in Russia, and I have an ongoing work in Ukraine, Vietnam, and Indonesia. And you might say, well, what does that have to do with Ohio? It turns out a lot, actually. And people who inject drugs are very similar worldwide. And the story that Jennifer just told is one that is everywhere. And one of the remarkable things is people have tried for decades to do big studies of HIV incidence in people who inject drugs. And universally almost, they have failed. And the reason that they failed is because once you have people in the study paying attention to the person, they feel supported, and then they're able to get into treatment, they're able to get their lives together, and the incidence goes way down. And it doesn't take, not that they don't continue using drugs necessarily, but they stop some of the like really bad behaviors, and just enough of them find their way that it creates a problem scientifically, which is a good problem. I mean, it's good for the people, but it's hard to do the study. So a lot of times the answer is to be able to walk along with the person, and and that's where communities can really make a difference without anything other than volunteer time in a way.
Yeah.
Now we go. Now we're going.
One of the few areas where there's been real progress in addictions with tobacco. Which is down enormously. I noticed it's still about 480,000 people die every year from tobacco, according to CDC. But are there lessons there? Basically, the lesson was it was not made illegal. It was made legal, taxed heavily, but kept legal. And the effort was to stigmatize the people who smoke. So no, it's no longer cool. You know, you smell, or you can't. You have to go, if you want to puff, you have to go 3 miles away or something like that. Is there any lesson to be drawn from that, or is it so different?
Yes. And as part of Mike DeWine's 12-point plan he just put out, which is all over everywhere, you do a search. One of his recommendations is a larger media campaign. And a lot of that comes from looking at what was done with tobacco.
Legalize the substance first.
Well, you know, what really worked with tobacco and what works with a lot of this kind of advertising, that your audience, you have to make sure that you target appropriately to the audience, right? So now, when you look at kids with tobacco, what really got them was social consequence, right? Because I went to a school once and they had asked me to do a talk on triple C's because that had dropped, chlorocidin, cold, and cough, because they had gotten away from opioids, but now they switched to triple C's. And so I hadn't done that before, so I went and met with kids and I said, so help me understand what will make a difference when I talk to you. And I brought all the awful things that can happen to you if you take too many of those, which included death, you know, which to me was the worst. And to them, it wasn't. The worst to them was sudden and immediate diarrhea. That for children is like the most horrifying thing that could possibly happen to them. So if that's what influenced them, that's what I'm going to talk about. And so with the tobacco, they were very good at that. But it was more than that. It was this cultural shift where you can't, look, when I started working in New York in '82, you know, we smoked in the office, right? You smoked on airplanes. People don't even understand that anymore. And now you're in an airport, you got to walk 3 miles to find a place. And it became those people, you know, ick. But you target for older people, it's more about lifespan, you know, what it's doing to your lungs. So, but that type of media campaign is tremendously expensive. And I don't think yet that Ohio is in a place, until we do more to reduce stigma, where I could go and say in a community in Franklin County, would you be willing to vote this levy to help save these people and get them off of heroin? Would you be willing to spend an extra $10 a month?
None of that was done with tobacco.
Well, here's where Mr. DeWine's going with that. He recently filed suit against opioid manufacturers. Okay, so he's mad. We did a press conference in Columbus a week ago Monday, and watch it. You'll see how mad he is. Because the more you look at the deceptive things they did, the angrier you should get. So we are hoping, he is hoping, and stated that he sent a letter to say you need to come to the table sooner because we got to have some money to start now. We can't wait to settle this 6 years from now. We need money right now. And so with that money, there are things we can do. But not my office. We can't do that kind of work. It's way out of his lane, but we can help get the money so it gets done. And that's like the tobacco settlements, right? It helped fund all that work. So yeah, we're paying very close attention and have researched it quite a bit. So you're right on, yeah.
Talk about some of the coalition building
Mm.
in rural communities. How does that differ in like a Cuyahoga County where you might have different resources available? Do the teams of people coming together look different?
Yes. Did you want more of an answer then? Yes. Well, Cuyahoga County really was one of the early large coalitions. And they have many. I mean, Cuyahoga County is a big, very diverse county. So, in 2011, maybe there was, one coalition. There's more than that now, but they've had a very active coalition with very kind of high level folks on it who have made tremendous advances. They have the coroner, the police are there, and they meet very frequently. They do conferences, they put out reports, they do a lot in their communities. They've done quite a bit, and they do have maybe more resources, but they have more people too, right? So maybe that evens out. In very rural communities like Pike County, right? Go to Pike County and you'll see what a struggle it is down there. They may not have the money, but boy, do they have the fight. And so much of this doesn't cost anything. It really doesn't. Certain things do. Absolute treatment. But you don't have to go to treatment in Jackson or Pike County. There's other places that you can go for that. So a lot of what we've had to do is, that's when we do these ideas conferences. Let's share. If you're doing this great programming in Cuyahoga, they put together a wonderful website. Costs about $100,000. Now, you can go copy that website and have all that stuff for $6. So you go spend $100,000 Cuyahoga County, which they can do, and you Clark County, which they did, and Butler County, you spend $6, you get the same thing, with the ability to modify. So there's so much variation, and that's kind of what's cool about being at the state level here, because I'm going to go to Cuyahoga, I'm going to see that, but I'm going to go to Pike, and I'm going to say to them, there's things you can do, like copy them. They developed the videos, they paid for the videos, all this stuff is out there. You don't have to use them, right? But yeah, great variation in all of that.
I wanted to touch kind of back to what you were saying, because I don't think it necessarily got addressed in regards to the legal status of people who are using injection drugs. So one of the things that happens is someone gets a criminal record, and then their job opportunities, are immediately reduced, and so it's something that they kind of carry with them. And I know there are some different initiatives. There's Ban the Box, on job applications and things like that, where people can ask that. But is there energy and effort being put into expanding drug court and expanding opportunities for people who are in the system to not gain that criminal status? Because we know that they're not, a lot of the criminal behaviors that are attached to drug use are due to drug use. So if you can eliminate that, if you can assist in that area, you can kind of eliminate the criminal activity that are associated with it. So what work kind of broadly on the state level is being done with that?
Well, one of Mike DeWine's 12 was expansion of drug courts, which is very broad. It's a lot more complex than that statement, okay? Because there's a lot of drug court flavors out there. So
Some good, not so good.
right. So there's whenever we make a broad statement, there's a whole lot that's behind that statement. But what they are helpful in is, if you get through this court successfully, we're going to remove your felony, right? We need punishment, number one, and we need consequence. Certainly, if you're trafficking, fentanyl, you need a penalty for that. Because if you're trafficking car fentanyl, you know you're killing people. There's no way you don't know that. So you still need that piece. We're watching it carefully though, and the first move is not to put people in jail. We just did $3 million in grant for something called quick response teams. That's where law enforcement goes out to a hospital or some,
I know it,
yeah,
I think if you've had a drug overdose.
right, and they try to get them to treatment. They are not trying to take them to jail. That's a huge shift in the law enforcement arena, right? And they carry Narcan now. This is so a lot of that's being done, but so you have a felony. What we're looking at, and again, his statement was some changes to workforce so that you incentivize employers through, there's a workers' comp thing we talked about, so that you incentivize employers to hire these folks. And you also train them on what to look for in existing employees and how to get them help. And to not have these policies where employees who have addiction issues can't tell you or you're fired, right? We need to change policy. But to incentivize employers to hire them, and then maybe once they're there a year, to get another kind of some sort of bonus. I don't know. And I don't know what the budget is, right? But certainly there's a lot of conversation about it because our workforce and our manufacturing industries can't find people because they can't find people who test positive. So, I talked to a sheriff and he said he was trying to place a child with a family member. He said, I tested 12 family members, all positive. I brought grandma in, she tested positive. So there's a lot. But we know it and we're working on it. And that's part of his, if you look it up, the 12 point, it'll be talked about in there.
I've got just a quick follow-up question. So you mentioned the law enforcement carrying Narcan. That's clearly not universal
Correct.
at this point. And there are some that are more resistant than others.
Yep.
How do you work with law enforcement to help them sort of understand?
Change their mind?
Yes, exactly. That's the word.
Yes. Well, you mentioned the sales background.
Yeah.
So this is my tip for anybody. This is one of my favorite sales lines. Ready? And action is just a request for additional information. Like that? That's a good one. Here's another one. Whoever talks first loses, but that doesn't have anything to do with this. But that's a good one too. So that's really how we look at it with law enforcement.
Yeah.
So if you say to me as a law enforcement officer, and truthfully, some of them have really very legitimate reasons. I mean, where they don't arrive before EMS. There's a lot of variables where they don't have money for Narcan. So then we got to figure that piece out.
Right.
But many times, I think it's that misunderstanding about it. It's this stuff you hear about, they're going to slug me in the mouth, or it won't make a difference. I'm just enabling them, right? We hear that. But, we heard the 3 strikes you're out stuff, like, whoa. So eventually, when they start to hear things like, okay, and I'm sorry, I'm kind of a salesperson, but if I'm presenting and there's an area where they're not carrying Narcan, here's some of the things that I say. And two, and so if you have a debate about Narcan, feel free to use these. We have a big range of people who overdose. It goes to that, it's a choice thing, right? And, when you looked at 2015 death data, about 75% were prescribed opiates. So I'm not sure about, choice in that. Or the friend of mine whose son first started using at 14 because his dad injected him, somebody to party with. So we don't know somebody's stories. What I do know is we lose lots of children under the age of 1 to this as well. And I can't change your mind if you believe that it's those people. And I'm going to try, but that's hard to change, some of those attitudes. But what I feel strongly about is I can't imagine that anyone would want to walk into a room as a first responder or anyone else, realize that there's a 6-month-old in an overdose state and have decided not to have on them something that would save their life. The other thing I'll say is, but it's up to you. The other thing I'll say about that is, this thing about should I save them? This is kind of baffling to me. So let's say, in a different scenario, that there's a mom. She's a soccer mom, and she's known to drink a lot, and she's had a DUI, and she's out driving, and she has her children in the car, and she gets in a really, really horrible car accident. And remember, she's known. So first responders arrive, your fire and there's a bystander, and they see she's trapped in the car. I feel pretty confident that they don't stand around and say, should we save her life? She chose that drink. She chose that. She's an addict. They save her life. How is this different? It's not. It's a human being. Right? So that's what I say about that.
The dead user has no chance of recovery.
Right. It's when, Narcan's a enabler. Narcan saves people, lets you breathe, is what it does.
Exactly.
Yeah.
Exactly.
You can't save them if they're dead. No.
I know there were questions over here.
I had a question, kind of something you both kind of touched on about the idea of incrementalism. Things like having access to clean needles. How, do you kind of spin the argument of these incremental changes kind of bring about these larger cultural shifts in people when you kind of go and talk to different communities?
Well, Attorney General doesn't really have a statement on needle exchange and all. It's a health issue, but here's how I feel about that. And I talk about needles in a different way. I know officers who spend a lot of time picking up needles. I know they're dangerous, really dangerous now. We need to do better with disposal of needles. What I have seen in terms of needle exchange are those programs, and particularly the one. I don't know all the programs. It's not my thing. It's health. But I can say to them, look at this program, or the program in Scioto. What was, to me, one of the best parts about it was the surrounding things that happen. So you have, you build relationship with these people. You get them their Narcan. You get them that. But I think that it's very easy. If I'm in a county and I say to them, "Look, your Hep C rates are like this, man." There's a lot of things you can do. Starting a needle exchange is a big step. It really is. And what happens if you make too big of a step, like recovery housing, you're going to get shut down. If people try to do recovery housing or needle exchange too early in a process, it's going to get shut down. And then they're frustrated. And then they're like, you know what, I give up. So there's a process of getting there. So if you're in a community that is ready, you're past stigma, you've done awareness, there's been some high profile deaths. You look at that and you say, we're ready. And let's talk about more aggressive things. But you have to really evaluate and assess the community first. You try to move something in when a community's like some of the communities where they say 3 strikes you're out. I can assure you, you're not getting a needle exchange there.
Where in the syringe exchange if that actually operates in full time?
Yeah, well, okay, yeah. So, but I mean, in general, you have to look for those things. Yeah.
Jose?
Thank you. I volunteer at a legal access project every Saturday, and I get to see maybe between 50 to 20 clients that come in. And I can tell you, first I'll make a statement, and I'm curious if this is right. I don't meet too many people that are using that want to use.
Mm-hmm.
They're likely coming in, and we provide them with, of course, naloxone, access to treatment, we provide them with testing, and then with clean needles so that they can stay well while they're using it. Can you, from a science perspective, touch a little bit on the brain? Because that thing that stands the premise that this is a disease, and it's not people really wanting to use, but rather once they're using, they likely have to use. Can you touch on that a little bit?
Sure.
And I know you're not an addiction expert, but you know a lot.
I know a little bit. Humans in general are a species that enjoys pleasure, and we seek pleasure, and actually most species, most mammals have the same pleasure system, and there's a little set of dopamine neurons in the ventral tegmental area, and they go to the nucleus accumbens. And actually, when I was a college student, my senior college thesis was on getting little rats to press a bar, and they got actually amphetamine injections or a dopamine blocker in the other part of the brain. That was a long time ago, so we know a lot about addiction. And addiction is really hard to treat. With opioids, the challenge is that it also affects another part of the brain. And that other part of the brain controls respiration, blood pressure, and a lot of other sort of systems kind of things. And that part of the brain essentially adapts to the dose that you're giving so that it doesn't have that effect. And then simultaneously you lose the effect of the high. And you have this chase of needing more drug to get a little high, and consequently gradually increasing your tolerance for the overdose. And with that comes along, it costs more. Just as a little anecdote, the folks we worked with in Russia were, some of them were guys that had been injecting for 15, 20 years. And they would go every year-ish, involuntary detox for a month, detox, go through withdrawal, supported withdrawal, solely to be able to decrease their costs. And then they'd gradually build it back up over the next year. But those were folks that knew how to manage it. They weren't getting infected because it was part of their life. Did they want to stop? Probably, but Russia, there's no methadone, there's no other support, so they did what they could. So what happens with addiction is we end up with this increasing tolerance. We go to prison, we go to jail. We don't access, or at least not much, hopefully. We don't access. We come back out. If we're not experienced, we go back to the dose that we were using before, and we overdose. That's one of the big groups of overdose, are those that have been in prison that come back out. The other big group of overdoses are younger people who haven't really developed the skills yet, because it is a skill. So managing your addiction. It's like there are skills, like ideally you use the same dealer all the time, who you trust, and you understand, who will tell you this is a good batch. This batch doesn't have so much. This batch has, I'm not sure about this batch. If you're going to different dealers all the time, you don't have a relationship. You end up with carfentanil mixed in, or as was happened over the recently, cocaine cut with carfentanil. You think you're just injecting cocaine and you're not even using opioids. It's going to take like a teeny tiny bit, and that's a death sentence. And you weren't even an opioid user. So there's a lot of market side things that are a challenge, but I think I mostly answered your question with my rambling sort of answer. But addiction is, I mean, just think for a second about your own vice.
Vices,
Vices, right? I would imagine every single one of us has something that we wish we didn't do as much as we did, right? And think about how many times you've tried to stop doing that. Behavior change is really, really hard. And that's without adding in this like neurological
I would say it's a
change in
physical
receptors.
dependence as well.
Right.
We don't think about the fact that people aren't getting high anymore. I
Right.
think that's a misconception that we encounter a lot working in the field, is that people think that people who are long-term drug users are getting high.
Right.
Like,
They're not.
They enjoy it. There's
Right.
no pleasure in
They're just
all
not
that
getting
anymore.
sick, maybe.
They're
they
just
don't feel like
avoiding
they're
withdrawal.
dying.
Yeah. They're just making sure that they aren't going to withdraw from day
Or-
to day to day to
right.
day.
Or so they can go to work.
And
So
so
they're
they
not
can go
thrown
to
up in the
work.
bathroom.
Yeah.
Yeah.
Can you touch on that? But I think there's a misconception also that people who have drug dependence are not effective members of society. I think that we always see the people who are, homeless and in the throes, or living in a drug house and don't work and don't. But there are a lot of people who they wake up and go to work every day.
Yes.
Just after they inject heroin.
Right. I mean, I think that everybody knows in their lifetime a functional alcoholic, right? It's the same thing. It's just the withdrawal from this is severe. And so before I worked for the Attorney General, I did a lot of volunteer work where I lived. And we took in a guy who was in drug court, and he was terrific, and I brought him early on, it's like 2011, to a training of law enforcement officers. And he was sitting in the row with me, and throughout the conversation, there was not really all these nice things said. And I remember he stood up and he said, well, I guess since I'm that, junkie, loser, I'm not sure if I have anything of value to say to you. And it was like, you? And it was early, remember, going back a ways. And somebody said to him, well, why do you just keep getting high? And he said very clearly, I don't get high anymore. I'm using so that I am not laying on the floor in my bathroom thrown up, or that I can be awake, or that I can go to work and be like everybody else at work. So I'm pretty confident that either with prescription pills or other opiates, that there are many people using among us and managing it temporarily until it gets worse and worse and worse. But a lot of people, like the woman you talked about, the grandmother, the woman who had used for how many years?
40 some years.
40 some years, and she was functioning.
Do you think that if we can remove some of the stigma that kind of drives people, because I think that one of the things that's happening is people are getting driven into isolation, and so like when we have isolated drug users, like that's when we lose people to overdose, and that's when people stop being able to function within society because something triggers that isolation to happen, and then they can never get back into the society. Like, how do you think we can
Work on that?
combat that?
I think there's a lot of different ways. What I try to work with a lot is getting people in recovery to be more vocal about the fact that they're fine instead of hiding. And I'm going to give you a very kind of clear example of a change in that we have to change how we talk about it. And I went to Trumbull County to a very large walk against heroin. And as people arrived, they all got a black balloon, and they signed on there who they lost, and then at the end they released them. And so we were planning a recovery hope event in the Hilltop, and we wanted it to be a very positive event. So instead of black balloons, it was colorful balloons that they wrote the best part about recovery, and released that and it was nice. And in the room were we asked Columbus PD and Columbus Fire to find the fireman and the officer who had saved the most lives to come, and we recognize them. And I think that by being positive and that you have a life, and you can come out of this and it's wonderful, and that we educate people about the brain. That's when we do education, a lot of what we focus on is the disease of addiction. And when people start to understand that, this happens very quickly, but we have to have really open dialogue about it. And I think unfortunately in Ohio, what's happened is that there's not a lot of people who don't know someone affected. And I don't like the fact that maybe that's a part of the change, but it is part of the change. So is there work? Sure. And there's certainly going to be some people who you'll never change their minds. But when I start seeing the church, what the faith people are doing, that's a massive change for that. Catholic Diocese did an event about a month ago. Catholic Diocese opened by the bishop, and they're very much about making sure that their doors are open to these folks. And so sometimes it's a little at a time, but we are getting there. If we take ourselves back 5 years, this was a very different conversation, and the stigma was far worse than it is today.
I want to go back to your comment briefly about working and being part of society. This is just sort of a funny little anecdote. So in that study that we were doing in those 3 countries, in Vietnam, we've enrolled a couple hundred people who are all people who inject drugs, and we noticed over time that we were beginning to miss a bunch of visits, that people weren't showing up, and so what had happened, and this is about an hour north of Hanoi, and in the town they had just opened this big Samsung factory, and all the people in our study got jobs, and they were still using, and so we had to schedule our visits in first thing in the morning or at the end of the day so that they could come after their shift, and they were perfectly fine employees, and they kept their jobs and did well and that sort of thing. I think the thing to remember is that there's a whole spectrum, right?
Mm-hmm.
So there are people that struggle managing it and are isolated and have trouble and have mental health issues that accompany it, and then there are people that are well integrated in society and function pretty well, and people can cycle through different phases as well, depending on what's going on in their life and that sort of thing. The other point I wanted to make, which goes back a little bit to the brain issue, is that it doesn't take long to build a I don't want to use the word addiction, but essentially tolerance to opioids, and that's why there are new guidelines for how long prescriptions should be, because basically within a week you can have an addiction of a sort, and in addition, you often, for some people at least, they start with that high that they get, and then that starts to fade, and then they go to a higher dose, and it comes back, and that's part of the transition from oral to injection. Is you can switch from something where you're not really getting high anymore to something that gives you a much sort of bigger push, and that transition is also often a really, really dangerous one, and people don't suddenly become only injectors. They sit doing both often
Mhm.
for a while, and then they transition to sort of full-time injecting a lot of times. And that can go fairly quickly or it can take a long time.
Mhm. But the problem today, however, when we talk about functional, is that when we're talking about fentanyl and carfentanil, we are in a very risky time.
Yeah.
Um,
You can't
this
predict
this
function.
is this is not something you can function. When you look at a sugar packet of fentanyl will kill 100 people, and if it's carfentanil, 10,000. Okay, so when we had this recent Franklin County situation with spike in deaths, is it 5 deaths
5 a week ago.
a week ago, and they're seeing that these drugs, was it marijuana, cocaine,
It's 5
Are-
overnight. 5 overnight.
5 overnight, are being spiked or mixed or whatever with carfentanil and fentanyl. Yikes. And so if you look at cocaine in particular, our death rates from 15 to 16 doubled from about 500 to over 1,000. So now you've got this, they don't have any tolerance, what he just talked about. And you're going to go buy some cocaine, for the weekend, which is what people do. And guess surprise, it's got carfentanil. You have no tolerance built up. It's a death sentence. So, with what we are in now in Ohio, there is no functioning. It's too risky. We are in a very bad place with these synthetics, and they're very difficult to stop when they're coming through the mail, right? So, we need to have a whole different. When we say to law enforcement, no more field testing. When libraries are carrying Narcan because people are overdosing in the bathroom, we're in a serious place right now with these drugs.
And just to be clear, to add a little bit of sort of science there, if oral morphine is your standard at 1, heroin is about 10 times stronger than that, and then fentanyl is 100 times stronger than that, so 10 times more than heroin, and carfentanil is 10,000 times stronger than morphine. So even if you're a heroin user and you get a little carfentanil, you're lucky to survive with full tolerance. It's an elephant drug, not a human drug.
Yeah, it's a large animal tranquilizer.
If you talk more about the lawsuit,
Mm-hmm.
what is the addiction rate for physician prescribed opioids?
Was the addiction rate? I mean, how many people who start on like a Percocet, Vicodin, become addicted? I don't know the answer to that.
The drug companies argue that it's way under 1%.
Pardon me?
The drug companies argue it's way under 1%.
I'm sure they would say that.
I
Yeah,
have
they have to
plans-
demonstrate that's not true.
Right.
plans
And I don't know that answer.
that.
Yeah.
Hospital prescribed opioids. And 2 months after hospital assigned opioids, only 1% still had it. It was just grossly misapplied to the
Mhm.
general population.
Right. And the lawsuit may have that in it. I've read it, but several times quickly. And that is easy to read if you're interested. It's we have a lot of documents, and even when I'm looking for them, I'm always looking for shortcuts because I have no time. So I go to Google and I do things like Attorney General lawsuit, and it takes me to the page on the Attorney General website where it is. It's on there. You can download it and take a look at it. So yeah, it may be in there.
And there are lots of elements here, really, right? So there are undoubtedly lots of opioids that are prescribed appropriately for people
Mhm.
for pain, and that's legitimate. What physicians historically have been sort of not done well, and I think the pharmaceutical industry has sort of been misleading about is how people do with chronic pain management with opioids and addiction in that context. And essentially the relative ease where someone can go from their knee replacement to needing it for a month because of the pain, and then having having an addiction issue. The number that not inverted, but a different number that is useful is about 75% of heroin users began with oral opioids. So there's some people root in from other drugs like cocaine or whatever, but most of that comes from oral
prescription,
first.
right.
And some of that's illicit oral drugs from like mom's cabinet or some friend or whatever. But so 75% were oral first. It's a big deal to sort of leap into injecting.
Although we're seeing that more and more. I mean, anecdotally, I think some numbers came out of Cuyahoga County. Their coroner does a really good report where their numbers for first start have been increasing, straight to heroin first. But yeah, the pharmaceutical companies said these were non-addictive. Very clear. They said they were non-addictive. Yeah, these were non-addictive pain medications. No, just they weren't addictive pain medications. Not over time, or you prescribe these, you don't have to worry about they're not addictive. Yeah.
That was the study they based their argument on.
Right.
They were not addicted.
Right. And they are clearly quite addictive. They still need to warn that they're addictive substances, even if used as prescribed. Everybody's different. Is part of it. You know, when somebody can take a Percocet and be like, that makes me sick to my stomach.
They did say it was less than 1%, that it's not zero. They did say it's less than 1%.
The pharmaceuticals companies?
Yeah, that's not
Yeah.
zero.
But they having listened to far too many pharmaceutical rep talks, they're incredibly selective about what they present. Which is why most most teaching hospitals don't let them in anymore. For the last 10 years or so, the pharmaceutical reps are just generally not allowed because they would pick and choose what they wanted to present. And so they might say less than 1% in their literature or whatever, but the way it's presented is this is not addictive. They definitely pushed. And I think, there are a lot of reasons why things happen, and that's clearly one of the, I think, underlying factors. I think in the southern part of Ohio, there's a huge economic part, and so it's complicated, and we have to sort of address each part.
There's many pieces to this epidemic. Yeah.
So we have just a few more minutes for questions, and if no one has any, I have. Go ahead.
What are some of the considerations between a preventive strategy, toughening audiences so that they're not interested in this, and strategies that are more targeted on those people who might potentially infect others? It's a very epidemiological sort of question.
No.
Good, it's not mine.
I can handle that one.
Good.
So just in general, you can think of sort of this realm in three boxes. You have prevention and treatment and recovery, right? So prevention is big and broad, and it includes anything you can think of to keep people from getting started. And that goes from when they're as little as you could possibly start, I think, to people that are already using cocaine and you want to keep them from switching to opioids, or someone who's a high school football player and they injure their knee and they get opioid prescriptions. That's actually a big realm, is athletics. athletics as an entry to substance use, and it's pretty tragic. So the prevention realm is really big, and a lot of that is just appropriate community support to make sure that you're thinking about it and being proactive about it, in my mind. Treatment does have sort of two purposes, right? Treatment, broadly speaking, is to help people stop using the drugs so that they don't overdose and die, so they don't have all these other negative consequences in their lives. But there's also treatment to prevent some of the bad things from happening to them that can then be transmitted to other people. So HIV, hepatitis C is about between 10 and 100 times more infectious than HIV. So it takes much less blood for it to be transmitted. You can transmit it more easily through other body fluids than HIV, so that's why you see so much more. And generally speaking, if you take a population and people who inject drugs who are novices and they're mixing in a sort of traditional network, the prevalence of hepatitis C will be about 70% the incidence will be about 70% after just 4 or 5 years. So it's really high, which is why we see so many cases recently. HIV just doesn't go up, and you need a longer time. So you have treatment basically for the addiction and treatment to manage all the other consequences. And then the challenge with addiction, just like our behaviors that we were talking about before, is if you get into recovery, you may relapse. The pull to do drugs is still strong, and when either bad things happen in your life, you end up with your old buddies, or just various circumstances, that pull will be there. So recovery is really a sort of lifelong process. In my mind, all of those stages requires their own special attention, and we don't talk enough about recovery. We don't have.
That's right. Yeah.
I love the idea. People do recover, right? So if you start someone on medication-assisted treatment, after a year, there's about a 50 to 60% chance that they won't be using. Is that perfect? No, but that's a 50 or 60% chance that they aren't using. And that year is actually the most critical one. So getting them started and getting them in, supporting them through that time is huge. But because it's not perfect, you have that potential later on for being drawn back in. And having more people willing to talk about I'm in recovery and normalizing that, I think will really help the whole continuum of prevention, treatment, and recovery. So we have time for one last question according to my rule book here.
So, nobody else has. So I was, you both know somewhat. What gives you hope? What gives us somewhat looking forward to the future? What gives you hope?
I would say every day something does. And so, okay, I'll give you a really, one of my favorite things. So there's a guy, his name's Dan Palmer. He's out of Lawrence County, and he decided, I'm going to make a difference as me, Dan Palmer. And he went and visited schools in Scioto County and started to learn about some of the really bad stuff, and sent me a letter, an email about some of the really bad stuff. And the newspaper there heard about it, what he was doing, about the really bad stuff, but that he was going to try to open up a place where there would be things for the children, soap and shampoo. And so he wrote me this very sad email on a Friday, and actually I left the building and cried. It's that awful, and I see a lot of awful stuff. And then Monday he called me and said, "Jennifer, you're not going to believe what's happened." Okay, he said, "My phone hasn't stopped ringing with donations. 2 weeks, people called him with donations. And he filled up that shop that was donated to him with toiletries and clothes and food and things for those children." He called me this week, now this is about 2 months ago, it's still happening. And he said, "You're not going to believe this, Jennifer, what just happened." Okay, Dan, what now? He said, "There's a hotel chain. And did you know, Jennifer, that hotels have to get rid of their towels every..." They're giving them to me. Me. I'm getting 400 towels. And you know what else they gave me? You know those little bottles? Boxes and boxes and boxes of those little bottles. He goes, "And you know what else? Those kids, they need to bathe. So I'm looking at this mobile shower unit. You know what? They said maybe they'd give me a big donation." And then, you know what else? Coca-Cola calls me. You're not going to believe this, Jennifer. Coca-Cola calls. They're going to give me jackets for probably every single kid who needs one in Scioto County. Coca-Cola finds him there and calls him. That's the stuff. And when I say one person can make a difference, we can. And I see it. That's one person and doing remarkable things. All the time I see it. But it's part of the convincing people that we can make a difference by just take a step forward, right? This is so much about compassion, right? When we talk about isolation, you bet. Isolation caused a lot of this. Hold your hand out and help them. That's easy to do. That's easy, right?
My answer is really short. It's people like Jennifer.
Oh, hi. That's so nice. Thank you.
That's true. So thank you, everybody.